Hello. Maybe we can start.
Sir.
Mrs. Sanjana,
Yes, sir.
you're ready.
Yes, sir. Yes, sir. I'm ready, sir.
You start.
Yes, sir.
I will just welcome her.
Yes, sir.
I welcome Dr. Pushpa. Thank you very much for accepting our invitation and taking part in this webinar. Thank you. Over to Mrs. Sanjana.
Thank you, sir.
A very good afternoon to one and all. I welcome you all to the session 3 of day 3 of the webinar. We have with us today Dr. M. Pushpawati, Director of All India Institute of Speech and Hearing, Mysore, with us as the resource person. The topic that is going to be addressed in this session is early intervention for speech and language disorders in children with repaired cleft lip and palate, recent advances. Professor M. Pushpawati completed her undergraduation, post-graduation and PhD from the All India Institute of Speech and Hearing, Mysore. She has over 22 years of experience in teaching undergraduate, postgraduate and doctoral students. She is a professor in speech-language pathology and the director currently. Her special areas of interest include disorders related to orofacial anomalies, disorders. She has guided 75 masters and 8 doctoral students for their dissertations and theses. She has been a member of Board of Studies and Board of Examiners of several universities in India. She has published 75 scientific papers in national and international journals. She had several extramural projects funded by the Department of Science and Technology, Imprint and ICMR. She has also completed 10 projects funded by the Aish Research Fund. She is a recipient of the prestigious Professor Rais Ahmed Memorial Award instituted by the Acoustic Society of India. With this note, I welcome Dr. M. Pushpawati and I request you to take over this session, ma'am.
Thank you, Sanjana. I'm audible, right?
Yes, ma'am.
Just share the slides.
Yes, ma'am.
Can you see the slides?
Yes, ma'am. It is visible, ma'am.
Good evening, all of you. I know 4 o'clock after morning, I think all of you will be listening to our lectures. And this may be kind of, for you, it might sound as very dry subject in the beginning, because when I see the subjects that we learn in UG and PG, few subjects I can say it's kind of, the emphasis has been given. For few subjects, it is not considered much depending on the kind of incidence and the caseload that we have. And this is one condition, that is the cleft palate, where we can say that it's hardly 1 in 600 live births, so not much focus has been given. So I'm here soon after my post-graduation. When I got my faculty post, I started teaching from 1996. And then just wanted to tell that this is a subject which I never studied thoroughly in my college days, and I ended up teaching that. So how exactly I prepared myself? So this is an overview of my presentation. I'll be just mentioning about the introduction, the associated problems, the speech and language problems, and focusing on early intervention and then speech sound correction, and then what is the take-home message. So moving on to the incidence and prevalence, let us just understand that what is the incidence and prevalence of cleft lip and palate in India. So if we compare the statistics from 1987 to 2013, you can see that even in the worldwide also it started at 2.07, and then now the recent studies highlight that 1.09 for every 1,000 live births. And in 2013, it says that every year we have 27,000 to 33,000 per year. So this indicates that there is a need of having these children need to be treated. They need to be given attention. So when I look at the review, earlier the focus was much given on surgical issues and not much focus was given to speech language pathology. Basic issue was they focused more on the effect of surgery and the different types of surgeries and modification of surgeries. But later, in 1950s, Zock, Morris, Mr. Bag. So if you refer all these books, the clear-cut information is given where exactly they try to describe each individual. And in terms of the phonological development, during those days, more of longitudinal and cross-sectional design was also used to highlight what are the kind of phonological development that is taking place in unprepared, also in prepared children. So yes, of course, from the beginning, it is clearly said there is a delay and deviant development of phonology. Later, the attention was shifted to understand the salient features of speech characteristics. So in 1978, certainly et al., he coined the word called as cleft palate speech. The moment we hear the term called as cleft palate speech, it's kind of a hypernasality, misarticulation, unintelligible speech. So these are the words that comes into our mind. In 81, a classic study by Trost and Cadman, they gave the word called as compensatory articulation and they described. Then different kind of protocols emerged to give the weighting for perceptual speech characteristics. And from 2000, focus on early intervention because, the surgeries, the free surgeries were started. So the efficacy studies have started and the instrumentation. So this journey clearly highlight that, from a time where SLPs were not recognized much, we are moving ahead. So how are we moving? We are moving to collaborate with the other professionals with whom we are supposed to work to provide the better treatment for these individuals. So what are the kind of problems that they exhibit? So this clearly shows that this is a heterogeneous group. We, as a speech language pathologist, always understand that there's a delay in language development, articulatory errors, resonance problem, and hearing loss. Then all these leads to unintelligible speech. Apart from this, there are feeding difficulties, psychosocial issues, and dental problems. So one thing that all of us have to remember is cleft palate can occur as non-syndromic or syndromic. So there are more than 100 types of syndromes that are associated with cleft palate. So naturally, the type of problems what we are going to see are more, especially if it is a syndrome. If this is a condition, then how are we going to treat? It is not one person's responsibility. It's a multidisciplinary team. The team consisting of plastic surgeon or maxillofacial surgeon who is responsible for providing the surgery as early as possible, depending on the protocol. And then we have speech language pathologist and prosthodontist. I have included speech scientist and orthodontist, parents, and clinical psychologists. So this is the kind of multidisciplinary team which is very much required to provide the better treatment. I'm fortunate enough to work with this particular team. So the journey has begun from almost, I can say, 2001, working with a plastic surgeon. Before that also I was working. So when we started working, we had many research officers working with us. This is a unit where we try to see the patient and try to provide the rehabilitation, assessment, everything together. So instead of referring the patient, you go to room number 10, 20 or that, we sit together. So the conclusion is drawn there. So all this work is basically with the effort of this teamwork. How do we understand? How do we understand what kind of problems that these children face? The children with the cleft lip and palate, whether it's repaired or unrepaired, they face a different kind of problems from infancy to preschool, school age, teenage. So that means that there's no stop. Like, the problem is seen. Infancy, they have a different kind of problems, but whereas in preschool, a different kind of problem, and teenagers, again. So that means speech language pathologist has a long journey to go with each patient. So we share much more information compared to the other professionals, getting to know about the patient. Why is this? This is because the problems are seen both at the level of speech, at the level of language. So we see from the infancy. So when we talk about cooing, babbling, first word, everything for normal infants we can mention. But when we talk about infants with cleft palate, we have, they exhibit delayed onset of speech. They have few consonant inventories. And the one thing which I want to highlight is they start developing more glottal stop at 6 months. If you see an infant, a normal infant, you might enjoy they saying, ba, 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 ba. So some kind of, the consonants are emerging. But here, it's not that, they're not saying anything, but it's So parents don't even know what the child is trying to say. They have few oral stops and alveolar stops. So this is the speech that is being seen in infants. At the age of 1 year, they undergo surgery. Okay? So the surgery can be done by maxillofacial surgeon or plastic surgeon. Whereas it doesn't matter because we want a child in front of us who has been corrected with the anomalies, especially what is seen in the lip or palate. It's nice to see this child taken at 2004. So it looks like, everything is done. What is our role? But here is the structure which has been corrected, but the function is not corrected. I'm not mentioning something to do with the lip here. I'm mentioning something related to the palate, which we will be discussing in. So because of this functional aspects, where the palate has not been given kind of, much functional aspects, the child will have problems. The problems are, especially now we move on from infancy, I'm moving on to the toddlers. So there is already delayed onset of speech, with restricted consonant inventory. So whatever the glottal stop it was there, again it is seen. And here they do have language issues. They have a smaller vocabulary, the shorter MLU, and slow acquisition of first word, who are receptive and expressive. But I say that, most often the receptive is better compared to expressive. So this is the language issue. So we can just say that, not only speech errors, there is also seen in language because the shorter MLU and smaller vocabulary. So this continues, in toddlers, especially when we are saying that compensatory articulation is persisting. The phonological process, there's a deviant phonological process, mixed nasality, dysphonia, and then unintelligible speech. Naturally, when they have compensatory articulation and they have hypernasality, it will lead to unintelligible speech. So this is the age which we need to focus, that's the toddlers, where now they are able to sit, they are able to understand at certain extent, and time for us to think about early intervention. So now, whether these children, when they go to school also, the errors persist. Okay, some errors might disappear, but some exist. But the speech intelligibility still remains the same. Here, the issues in terms of social interaction and teasing by peer groups. So all this will add to the problem, which will make the person to have less self-confidence. Even though he knows to answer the questions, he will not be able to answer because the moment he wants to answer, his speech will not be understood by the peer group or they will make fun of him. So in that way, even though he has potential, we are not able to understand that whether he has potential or he is not able to perform. This journey again continues in teenagers, but here again the problem is more of the interpersonal relationships, and again acceptance by the society, the time for them to get married, and they will not get the good alliances, so many other issues, and along with this, the speech problem. So most often the patients what we get, they come to us at the age of 23, 24 years, and they say that, Madam, you do something because next week there's a proposal for our daughter. What do we do at 24 years? And they want us to repair within 1 week. So this is the ground reality of the expectations from parents, and these speech language pathologists saying no, it is not possible. Why exactly all these problems are seen? All of us know that the speech stimulation is very much important for the development of language, but here there's a poor speech and language stimulation from the parents and persisting middle ear disorders, otitis media, poor dental problems, overprotection by parents. Some parents feel that child should not speak. If they speak, the size of the cleft will increase. And they try to accept the unintelligible speech, even though they come to the therapy, we do tell them. But since they accept the unintelligible speech, most often they tend to develop that as a habit. Of course, the poor social interaction, the cognitive deficit. Nowadays, the studies are focusing much on cognitive linguistic deficit and the syndromic cleft. As I said, if we have a syndrome such as Down syndrome or velocardiofacial syndrome, we tend to have more associated problems, and because of all these causes. So now, what are we going to do for these children? Yes, now we agree that at the 1 year, they have undergone surgery. They're just sitting in front of us. So are we going to give them therapy, or should we say that it come later? It's not so. So these are the names which I think most of you are familiar with: Chapman, Harding-Jones, and Judith Cadman. I said they have done extensive studies. Not only the studies related to infancy, it's also up to the school age children they have covered. I'm trying to provide the emphasis on the kind of the studies that are going on, and also the Indian scenario, so that you will get to know where do we stand. Are we too behind compared to the other studies that have been done? So this is the major focus I'm going to give of next few slides. So these studies, which clearly highlight that there is a difference. So what happened in Indian scenario? Indian scenario, similar studies were being done. These are the articles which I'm quoting. It's the SRMC team where it's led by Professor Rupa Madam, Dr. Savita, and Dr. Balasubramanian. So these three of them initiated the work. And since they were working in Smile Train, along with Smile Train, so they could initiate. And then the documentation started. Till then, there was no documentation. So in 2000, the scenario changed because all the free surgeries were initiated in India, especially from Smile Train. What exactly we did? So I'm just highlighting what is the kind of work that is being done. We also wanted to understand the speech and language issues in toddlers. So focusing more on phonological processes and the compensatory articulation and the speech intelligibility and the language parameters. See, this is an age between 3 to 5, very sensitive age. They might have started their preschool. So we need to understand. So that's how a PhD was done by Dr. VP. And we could get to understand that, the kind of phonological processes exhibited by these children are completely different from what has been cited in the literature, because, it varies according to the language. And the compensatory articulation and the phonological process, whatever we saw between 3 to 5 years, few were disappearing, but few were persisting. And we could see that, they are completely different compared to normal children, the phonological process exhibited by normal children. And then, so if we know that these children are exhibiting problems, what are we supposed to do? We are supposed to initiate early intervention, a kind of an evidence-based. So a time for us to just peep into the kind of, the studies that have been done, the publications have been done. So everywhere it says a meta-analysis, there are 4 to 5 articles which talks about the early speech and language in children with non-syndromic cleft lip and palate. So if we know that, are we going to just sit and keep on analyzing, or we should start therapy? If we have to start therapy, how do we go about? How do we go to document this? It's nice that plastic surgeon or maxillofacial surgeons show the picture before the surgery and after the surgery. Parents are so happy that the child went inside the operation theater, came back after 10 or 15 minutes. Sorry, not after 10 or 15 minutes, maybe after 4 to 5 hours, and was in ICU for half a day. Then he came. So they're fine just seeing that. But what are the kind of things that we are going to show? Are we going to show that, immediately soon after the surgery, the child is going to say 1, 2, 3, 4. Earlier, he might have said 1, 2, 3, 4. So please remember, the child sitting in front of you at 3 years or 2 or 3 years, when you just talk to him and you ask him to count, he just says, which you can't understand anything. And we are supposed to work and make the child to say 1, 2, 3, 4. The journey is not so easy. It's easy that I can imitate, but it's not so easy. Then what are we supposed to do? We are supposed to look for the early intervention programs that are available, that are cited in the literature, because here the paradigm shifted in 2000, where they started focusing on the need of speech language therapy at the age soon after the surgery, and then documenting and showing that these are the kind of changes, subtle changes that are being seen. So this early intervention is nothing but it's a service given to a very young children with special needs, and a child with a cleft lip and palate falls into this category, and birth until the child turns to 3 years. So now I said 1 year the surgery is already being done. So we are here to take for the therapy. And when we are working, we are supposed to work both on receptive and expressive. Along with that, the articulation, pitch, fluency is not much of a problem. Volume is, yes, of course, we have to improve. Now, this is both, I'm just taking the non-syndromic and syndromic together. These are the broad areas we need to work on: the cognitive motor and speech and language, social and personal, and self-help skills, especially in the syndromic case. Now, how exactly it is going to help? It improves both the developmental and education gain. So if they undergo therapy earlier, they don't have to go for, in future, the different kind of intervention. And it helps in terms of building their self-confidence, the stress, the frustration, everything will be reduced. So that's how it is required for early intervention. The basic feature of early intervention is we are, if we say that we are the stars, along with that, we also have parents. Parents are the ones who are going to be with us, and our therapy in the beginning is mostly oriented towards the parents and training the parents. Okay. If I take an example of stuttering, apuophonia, voice case, easy that within 15 to 20 days, or at most 1 year, you will be able to show some improvement, saying that, this is what is the improvement. But what happens here, the child has got articulatory errors, the resonatory errors, the unintelligible speech, the dental issues. So it is not so easy. So that's how, we need to spend so much of time. And these are the 4 areas which are taken. And is this the therapy is going to be different compared to the other language disorders? No, it is almost same. But there are specific strategies that have been listed out, especially enhanced milieu teaching and focus stimulation. So focus stimulation is one thing which has been highlighted in most of the literature articles. So I basically worked using this technique. So I'm going to talk about this technique as it has been widely cited. How are we going to prepare ourselves? So this is something which I initiated at All India Institute of Speech and Hearing, the Early Intervention Center. I was fortunate to get a project for 3 years by Department of Science and Technology to show them the efficacy of speech and language therapy. So this is a kind of setup because I wanted the kids to feel happy to come to us. Otherwise, we will be telling them to do some things which they can't do it. Example, I'll tell you. If just ask him to say, no, I want you to say, ha. They will say, and I keep saying, no, you say ha. So they feel that this is a place where we ask them to do something which they can't do. So just made it so lively, and they should feel happy to enter into this. And the first thing is, for few cases, since it's a 3 years project, I sat with the cases. I counsel them particularly. I try to use more of the educational aids, highlighting their how exactly it has gone wrong, what happened and how the speech can be corrected. And we try to evaluate their awareness just to know whether they know about speech therapist and our role. And this is one of the article by Mrs. Indu and team. We came to know that they don't even know anything called a speech therapy, and they were not aware on many issues. So that made us to think that we need to counsel them and then go ahead. So first thing, so we have a child sitting in front of us. Basically, we need to do the assessment, trying to understand how the speech acquisition, the language development, everything is initiated, and reels. There's one test, MacArthur inventory. There's one of the tests which has been cited in the literature, very good test. I think in Manipal, they have adopted. So please just go through this. This is used in case of cleft lip and palate. First thing is, I advise everybody, just allow the mother and the child to have interaction. So this mother and child interaction is very much important. So here, when we do this kind of interaction, we try to analyze what are the kind of vowels uttered by these children, the consonants, and we further classify. See, we need to understand the consistency of production of these vowels and consonants, and the quality and the quantity both. Are they saying the stops as stops or glottal stops, fricatives or the compensatory articulation? These are the speech parameters. Meanwhile, we have to see the language parameters. Here, we also analyze the language of the mother, because we need to know that what is the kind of interaction she has, how many words she's describing, or what is the kind of, the reinforcement strategy, all that. So these speech and language parameters, so this is how, see, when we do the reels, usually we don't get to see these kind of information, because, that just says receptive and expressive. This detailed information will surely help you to understand what are the kind of parameters to be considered. Of course, SALT, as all of you know, that is one of the method which you can analyze. So we started using the SALT to analyze, especially we wanted to know the number of words, the total words, all this. And we had 30 to 40 mothers who enrolled, and that's how we had a different kind of experience. Each mother was different. So we analyzed their speech, and then we started providing therapy. So first we had to take a baseline and then start intervention, and then we try to measure. So in whole this early intervention, as Shearer, who is the person who has worked extensively, she spoke about increasing the consonant inventory, development of vocabulary, and to increase oral airflow. These are 3 goals. So how did we go about? So we took these goals. When we say oromotor, oral airflow, this is not to improve the velopharyngeal closure. This is, see, till now the child has doesn't even know how to contact the tongue with the palate. Okay, there's a place of articulation which is shifted. He's not able to build the air pressure because of the velopharyngeal closure. If you just ask him to say pa, he'll say You ask him to say tata, he'll say So we wanted to make him understand that for speech, he need to have the oral air pressure, which is supposed to be there. See, this is what I wanted, not like So what we did was, we just picked up these small things. If you just see the book by Anne Kumar, she talks about these devices which cost you around 20,000, 30,000. But what we did was make in India kind of a small thing which parents can afford to use at home. We bought all these things just to initiate. The kids also felt very happy to play with this, and we could build rapport and then go for motor exercises. I don't know, many of you must have seen this soon after COVID. This has been extensively used to improve. So this also we started using. How did we do? We didn't want the blowing exercises, all that which is being described earlier. We just made it in a simple way so that the child is motivated. So there's a goal set for this child that you have to blow the ball from one direction to another, so that he feels happy. And you will get to see a different kind of cases here. I had this small Abhay and this one Seascape that we did. So we just took a pipette and we took a lamp. On that, we put the pipette and we had put some thermocol balls. And then I just asked the child to blow. So she was happy doing this. And then I was trying to give her the difference between when she closes the nostril, she was able to do it. This is a kind of visual feedback that we give. And not only that, a simple blowing activities where they enjoyed doing that. So this is something where listening to. We took this pipe and we used it, and Abhay was so happy to listen. So this is how we use simple methods so that which could bring smile on child and the mother and of course in me also. So why did this is Seascape? This I wanted to show that this Seascape which is available in the market costs 30,000. We just spent around 1,000 rupees at that time and just there's a pipette on a lamp and then we just had. So these small things really helped me to go ahead with these activities. We need to have vocabulary building also. We selected small vocabularies which are functional. So when we are trying to increase the consonant inventory, we should also focus on the vocabulary growth. So naturally, the familiar people, toys, and a few of the attributes, what is required for child's day-to-day was selected, not what I want. So in that way, the words also simple syllable structures were used. So this is the focus stimulation method. Just focus on how I am demonstrating. So that's how I'm happy because, he could see. The focus stimulation is nothing but you select the target word and you have to speak to make sure that 70% of the time that word should appear. Here I'm using ball. So I said, you ask the ball ta, ball beka. Do you want ball? Do you want a small ball or a big ball? Okay, I have got a red ball. Do you want this red ball? So when I'm saying this, the word keeps appearing. So this is what is the stimulation which is focused on the particular target. So this is how, initially I just started working with, and then fortunately these two young ladies continued working with these kids. Ultimately, when we started analyzing what was the baseline, what was the level mean length of utterance, what happened after 10 sessions, 20 sessions, 30 sessions, 40 sessions. When we started analyzing, we could see that there's an improvement in MLU, the total number of words. Of course, it varies from child to child, it depends. But nevertheless, that we could see that there is an improvement. So this is what I want to convey to all my dear students. You don't have to wait for some 50 cases or 30 cases. Even if you get 1 or 2 children, you can start documenting systematically and you can start publishing. This is what is evidence-based practice requires. And total utterances, total words, total number of different words. So all speech parameters, language parameters can be analyzed. So now we'll see. This really, now I'm showing that there's an improvement. So how do I show that, yes, there's an improvement? This is a case, impana, a success. Whenever I think of success, impana always comes into my mind. A Peary-Dobbins syndrome and an educated mother. When they came, the first session, I just told whether you speak to your child. She said, yes. Then we said, okay, we'll observe her interaction. So this is how she interacted.
Yellow color, orange, red.
She is speaking. There is no attempt from the child.
Blue. Very good. Blue.
So here you observe that mother is doing, but only thing is there's no response from the child. Mother is not making any effort to make the child to say that. So after our sessions, now you can see that how she. So here she started giving a lot of feedback and focus stimulation where she's trying to highlight puppy, all that. So this is how we need to document, and the parents were very happy for the kind of improvement that was received. So these are the people who have extensively worked in this area, especially in the early intervention. And Catherine is the one, please just log on to Leaders Project in the internet. You get to see a very good information, especially the materials pertaining to compensatory articulation and therapy. Okay, the success, whatever is being highlighted, is more of better communication. Mothers were able to provide better stimulation. There is a change in the phonetic inventory and many things, speech sound inventory, speech accuracy, everything. So that shows that early intervention is very much essential. We speech language pathologists have to initiate and start working. So we started documenting this, and then just to say that it is not only that we need to just record in our book, we need to publish. So there are a few 6 to 7 articles we published. So thanks to these research officers who worked with me. Now, okay, it's 3 years over, the child is able to now say, but I never focused anything on correction of articulation. So after 3 years, maybe the toddler's age or school going at 5 years, they come to us. When they come to us, they have misarticulation. So now, if we try to analyze why, what, how to go about, there are many books, but all the books talks about you create awareness, you give feedback, but the efficacy is not much highlighted in this. There are 7 articles on efficacy on early intervention, but not much on therapy. So this made us to think about what are the kind of speech errors that are seen in school-going children. I'm moving from early intervention to school-going children. So this is, all of you are aware that their errors can be classified as passive, active, and hypernasality, nasal air emission, compensatory articulation, all this, which we are familiar with. Here, 3 sets of sounds, stops, affricates, and fricatives. These are going to be substituted at different levels. Pharyngeal level, laryngeal level, glottal level, mid-dorsal. So that's how they're called as pharyngeal stop, laryngeal stop. Very easy to define, but difficult to eliminate the compensatory articulation. So for everything, what is required is the velopharyngeal closure. Now, this is the culprit because the velopharyngeal closure is not happening. We are ending up with having nasal air emission. We are having hypernasality on. So this is what I said, Trask Cardamom's classic study where diacritics were provided. So all the anterior sounds are substituted at the level of posterior sounds. So this is posterior level, glottal level, pharyngeal level, laryngeal level. So this is what is compensatory articulation. And we have to now make all these sounds to shift to the anterior. How do we do it? Very difficult to give them the feedback that, the back portion of your tongue is touching the pharyngeal wall. Very difficult. So in that way, this is exactly a challenging period for us because most of the time, the air emission is taking place. And let us just understand this is the work by what I said in a leaders project. So here you can see.
So it's not exactly alveolar where the t and da are produced, and it's not velar where the ka and ga are made, rather right in the middle.
So here
Next,
the tongue is raising,
producing
but
these like dorsum, so it might look like.
we'll just see what
for
happens
puppy,
in
it
dot
might look
stop.
like
She's supposed to say pa, but ended up saying ha. So this is how we need to analyze the compensatory articulation. So after this, we need to assess both perceptually, objectively, to analyze how much they have a problem. Perceptual analysis is a gold standard, but anyway, there are so many variables. We should always correlate with the perceptual evaluation with the objective evaluation. So the standard protocol is by Henningsen. Dear students, this is a standard protocol. If you want to get your publication done in the national, international level, most often this is being used. Like for voice analysis, we use Cape, all that. Similarly, Henningsen's et al., they have given where hypernasality, audible nasal air emission, everything can be analyzed. Speech understandability 0, 1, 2, 3. The terminology is given. So we have been using this since almost 12 years. So now this is the objective evaluation. So what is this picture clearly shows Dr. Satish doing the nasal endoscopy. I'm talking this in about the work that has been done in 2004-5, where we started doing this nasal endoscopy. When we say velopharyngeal closure, this is the velum, this is the posterior pharyngeal wall. On either side, we have lateral pharyngeal wall. So here, speech language pathologist is sitting with a plastic surgeon. Plastic surgeon is depending on us, what is our impression. This is what is the interaction that takes place between the SLP and plastic surgeons. So here we are asking the child to produce. So you can see the movement, the closure is not taking place. We can see some gap that is existing. So, and then we have to decide how much is the gap? Is it a very small gap? So this is how, this is the back push, this is the velum touching the posterior pharyngeal wall with the help of lateral pharyngeal wall. Okay. So now if the gap is very small, then he will ask me whether I can take first speech therapy for 10 to 15 sessions. Then I agree, then we try, and then I say that the child is not stimulable, then we can go for a pharyngoplasty. So this is the decision depends on us because we are going to give therapy. And then after that, we moved on to understanding videofluoroscopy, MRI, all that. So this is a work that we initiated in Vikram Hospital in Mysore with the collaboration of, again, Dr. Satish. We started in doing a cath lab as a kind of, trial and error whether it is really going to work or not. So we didn't know whom to call because you know that when we talk about videofluoroscopy, a lot of radiation issues involved. This is like, it was started mentioning in many of the articles. So I felt that, we have to start using this. So then Dr. Satish himself became a subject. And then please understand how exactly velopharyngeal closure occurs. This is a lateral image. I'm not showing the anterior image. Here, this thickened area is the velum. Then you have the tongue. This is supposed to touch the posterior pharyngeal wall. So when the entire analysis is going to be done, we will be there along with him, and then we analyze. So I'm just showing you the normal velopharyngeal.
Nela, nela, nela. Appa, appa, appa. Abba, abba, abba.
So this is the complete closure. So now let us understand what happens in repaired cleft. So here it is clearly see the gap. The velum is not touching the pharyngeal wall. So we try to analyze how much is the gap, whether we can take it for further surgery. So this is how we take the still image and then we just mark it saying that, this is the kind of, tongue and the velum, posterior pharyngeal wall, how much is the gap? Can we just try about? So based on this, we will plan. Along with this, we also recently tried with, this is one of the doctoral study that was done by Aparna with, along with the plastic surgeon, Dr. Krishnamurthy from Mahavir Jain Hospital, Bangalore. We went for further one more step of, analyzing the resting gap size, velum excursion, how much the velum is raising, how much, when it is relaxing, the kind of gap. So this is the important issue for deciding the criteria. In case if you are very much familiar, you can do it. Otherwise, I think we were depending on the visual inspection and the trial and error. So yes, after doing this, we started documenting what was the previous before and after therapy. So this surgery. So effect of furlough double opposing Z plasty. So this is the one which is done for correction of philoparental closure. We started documenting the pre and post operative. Speech language pathology should understand the kind of interaction that they're going to have and the kind of outcome. It is not that every day we sit and discuss. That doesn't mean that we can document. So we need to document and then publish articles so that we can say that these are the role of speech language pathologist. The next is till now I spoke about the images, how we can use it. Now moving on to the acoustic analysis. Many of you are familiar about the nasometer, which was introduced in 1986. We have various models, 6200, 6400, 6450. Similarly, we have one more instrument called as nasal view, nasal visualization system. The principle is same, but the filter characteristics are different. So you cannot have the normative data, whatever you developed for one instrument to another. It can be used for assessment, rehabilitation, research. Almost 30 papers have been published using these equipments because it really helped us to understand. So this is a way that the setup for doing the nasometer. The stimuli we have developed in Kannada, Tamil. Tamil was developed by SRMC, Telugu, Hindi. So we have oral sentences, nasal sentences, and when we take a nasogram, this clearly shows that for oral sentences, we end up having 10% nasalence, and this is for nasalence, we end up having more than 40%. But when a child says the same thing, here this is kage, kalu, kappu, you will have around 13%. When we ask a person with a repaired cleft palate, he says, you end up having 43%. So you can see the nasogram, everything shifted. So we usually analyze the nasal distance ratio and the other parameter. We have to have a normative data, but there are a lot of variables we should have across the gender, across the length and type of the stimuli, across language. So why? Because the size and the shape and the surface of the infraglottal, supraglottal structures keep varying according to gender. So several studies have been done because we know that Kannada has a different kind of dialects, Mysore dialect, North Karnataka dialect, and then we also have in Malayalam different. So across language we published many studies. So these are some normative data that has been developed. Unless we have a normative data, it is very difficult to interpret. Before the surgery we can have, and after the surgery and after the speech correction. So this will provide us whether we are achieving the normal speech. Yes, apart from acoustic analysis, we have aerodynamic measures. A lot of parameters are there in terms of linear flow rate, laryngeal airway resistance, all these, some studies have been done. Next one is acoustic analysis. Thanks to Natraj sir, you taught us the basics of acoustic analysis, the spectral characteristics. So we did a study that you can see spectral and temporal parameters. It was done in McWilliams, and we started working for one of the PhD, and we could see that how exactly, see the spectrogram of this palette. Nothing is visible. The transition duration, the fundamental frequency, if you want to see, you can see, but the VOT, the closure duration. So this is how the nasality is masked. Then we can also use this to compare between before the therapy, after the therapy, or after the prosthesis. So meanwhile, in 2007, we got to know that there's something called as nasality severity index, similar to dysphonia severity index, a multi-parameter approach. So we thought, why don't we try to do it? So this requires a detailed acoustic aerodynamic evaluation, which was done by Navya for her doctoral thesis, and we arrived at similar kind of formula to find out the severity of nasality. So this is to say that, but it is, you need to have instrumentation. So the objective evaluation. So this is more reliable. It gives the cutoff point. So you can say mild nasality, moderate nasality as based on the cutoff point. Then after doing all this, find out how to go about articulation therapy. Till now we spoke about speech therapy, language therapy. First thing is, we have to make the child hear the target sound, the error sound, feel the difference, see the sound. These are the kind of basic philosophy that we have to understand. Unless and until the child understands that when I'm saying ha, there is a nasal air emission, so make him to hear his own nasal air emission. So he heard, yes, when I'm saying that. So this is how small tubes gadgets were used. This is nasal visualization system. Again, it helped. Place of articulation. Here, both place and manner both are sacrificed. Place is more sacrificed. I'm trying to highlight that anterior is the target, whereas she had the posterior placement. We need to eliminate, modify, and then help them to understand that nasal air emission should be avoided. So after assessing the articulatory errors, we have to give them the perception training followed by production training. Van Riper talks about perception training. There are no particular articulation therapy technique for cleft palate except McAbey, who has given a multiple phoneme approach, but it was in 1982. Now it is not much used. Now they go by the framework of having the working for both perception and the production training. She's Ann Kumar using the small straw, making understanding, yes, there's a nasal air emission. Then she'll make him to listen. So inter and intra discrimination both. Should have a recorder to record and then to show before and after surgery. Visual aids, a place map, a lateral view, and then some reinforcement strategies we should have. So when we start off, have gloves, because we need to give them the placement. So have some cotton swabs or a sterilized spoon, so which mothers can do at home also. Then how do we go about? So we need to provide a model to the mothers. Here I'm trying to give more on awareness. See, these are the therapy strategies that they have given for different sounds. Example, I'm telling you about the glottal stop. How do we go about it? So there's nothing called as, is this really going to work out? In stuttering, you have many therapy techniques, and we have some efficacy studies. Similarly, we wanted to find out. Right now, a study is going on by Sushma, where she's trying to highlight about before and after providing articulation therapy, how the improvement takes place. So we have to work on awareness and as well as giving the feedback. So this is one of the old video. The first stage is we are trying to help the mother to understand, and she does it in front of us, and then later she should be able to do it.
सिखाऊंगी कि पा शब्द जो है कैसे प्रोड्यूस करना है, कैसे बोलना है। इसके लिए पहले एक गहरी सांस लेनी है, फिर बाहर हवा से मुंह से हवा निकालनी है और फिर बोलनी है। मैं करके दिखाऊंगी, फिर आप सीखना। पा एक बार और गहरी सांस लीजिए। पा
So let's see the impact. So take home message is that we need to involve the mothers. So this is one more. Here we focused more on reducing the rate of speech and improving the contact between the tongue and palate so that the speech improves. So this is how the articulation therapy can be given. And here a few samples of, skip. Some problem with this. It's okay. So the next one is prosthodontic management. So not everything is so nice, success stories, whatever I discussed till now. There are many failures. So when we get an adult who comes to us at 22 years, 23 years, and he says, I want to get married, you make my speech normal. Then we ask him to open his mouth. This is what is the reality. So that's the time where we realize that we can't take him for surgery. There are already 2-3 surgeries of failure. Or sometimes they are not willing to undergo. So this is the prosthesis which is being given. And very much we have to focus here of the how much length and then also the lift, because this is a portion that is going to help to achieve the vilopharyngeal closure. So we just did a project to find out whether it is really going to help us around 6 to 7 cases, just for 1 year, not more than that. And we could find that, if there's a really improvement, the spectral parameters, they showed considerable improvement. So this is again with the collaboration of prosthodontist. Then again, speech scientist. So this is something where till now, whatever we try to do is we try to collaborate with the plastic surgeon, maxillofacial surgeons, and then we started working. Then there was a time where I had to think of, this nasometer is costing around 10 to 12 lakhs, what to do for it? Why don't we think of, Make in India? Aish being a premier institute, it was way back, it's in 2013, a collaboration was started with IIT Guwahati, where I just shared the information of, we need to have a dedicated app where a child or an adult can use it on his own. The plastic surgeons can use it on their own to identify how much is a nasal value. So this is what is required. So it's called as nasal speech, and the proposal was submitted to the imprint, the PM's initiative of Make in India. So around 1.3 crore was sanctioned for this. It's when it was sanctioned, a group of scientists, these are the scientists who worked with us. They came and stayed at Aish for every year, 3 to 4 months, and 3 of them completed their PhD. Dr. Vikram, who completed PhD in the area of cleft lip and palate, right now working with Shearer. So this is how their journey into the cleft palate, and the rest of them also completed their PhD. So with this project, Girish is to submit his PhD of how efficiency of this nasal speech that we have developed. A few faces are familiar to Nataraj sir and all the students. You might be smiling looking at these slides. Vasudhaiva Kutumbam, students who were here, they moved on to different places. So in that way, you can see them as a faculty of DASIS, Harvard. Few of them are there in DASIS Institute of Speech and Hearing. Now what next? It's time to work from home. So my next target is just trying to work on the telepractice. So this is, there are 3 articles on this telepractice. Why I'm thinking of this telepractice is, we have, when we say that, 23,000 to 38,000 children are born with cleft lip and palate. Where do I find speech language pathologists working with them? So at least we need to initiate something on that. So my next study is focusing on telepractice for children with cleft palate, and basically focusing on, again, training the mothers and implementing it. Till now, whatever I worked was in offline. So now it is online. So I really don't know how long we are going to be there with the mask, the pandemic crisis, the Delta, Gamma, all this, the new vocabulary. So now this is the next venture that I'm trying. How are we going to equip ourselves? See, it is when you start working with, maybe you will be working in a hospital or an academic institute. Make sure that, don't list out the things, it is not possible. Start from your own level. So this is how I started writing books in Kannada and few are in English, developed a few materials so that the student clinician should have this material when they walk into the clinic and they start working. So this is how I worked. These are two books that I wrote for the flippant palette. And then time to reach to media, the social media, we started highlighting their struggle, and Nivedita is one familiar face. So she's, I'm seeing her since almost 21 years. So she shared her information, her struggle, and that's how we use their success stories. Started writing articles. Please write articles. And now I see, many of you have started writing, and unless until we write and tell about our role, people will not understand. So this is something public education is very much need of the hour to highlight. Then a lot of challenges between when I start seeing the clinical and research, how to give a blend to these. A gap between theory and practice is very much required. Many times when I start teaching in the class, when I started in 1996 or 98, for many things I used to say that I don't know, I don't have any video to show. Now, that is something, it was a challenge that I had. Now, based on that, I started writing projects, all that now for few things, whatever now I'm showing, it's all the work that has been done. So this is just to say that, don't ever say that it is not possible. It's think out of the box, start working hard. And when you have to say that, I'm working in this field, there should be something considerable amount of work which should bring a satisfaction within you. So one thing is, for the past 2.5 years, yes, I'm not into much of research, but anyway, my students are there and I'm still teaching. People are not interested to come to work in this cleft palate because they say that it takes a long time and immediately they can't make money. They have to work for 1 year, 1.5 years, and the lack of interest. Caregivers comes and they see that, ma'am, when I went to plastic surgeon, within 2-3 days, everything was over. And they told me, you go to speech. You're a speech doctor, no? So I'll stay for maximum 10 days, madam. You do whatever you want. I don't have tablet. We don't have tablet, tonic, operation to make it. So it's attrition. So initially they'll be happy, but later they will not turn up. This is not only for cleft palate, for many of the cases. The role of SLP. You can work in academic institute if you're interested in working with cleft palate children. Work in clinics. If you are working in academic, just don't keep on citing the examples from the book and say that in that context, so and so Shearer did it, Chapman did it. When are we going to talk about the studies that have been done in our own lab? So that's how, unless you start working with the patients, I don't think that anybody can say that they are good teachers. I always feel that the clinical exposure is very much required for a teacher. So when you start seeing the cases, nowadays all of us have smartphone, take a consent of the patients and the caregivers, start documenting it. And collaboration, I'm really happy for those who are working in a hospital sector. You will be having so many cases. I don't get that many cases. Few cases, whoever who came, they helped me to understand them, to give therapy. And then the research is something where you can do from the telerehabilitation to efficacy studies. So now more than 100 hospitals are providing free surgery, but they don't have SLP. It's a request. I don't know how many of you are listening. Even after the study, if one person is interested, okay, let me work in the flippant palate. It's interesting. That means it gives a lot of confidence that I'll be working with plastic surgeons. I'll be observing the surgery. I'll be using the imaging techniques. I have showed videofluoroscopy. I have not gone for MRI. When we thought of MRI, it's around 10,000, 12,000. It's very difficult. So we have to write one project to get this amount. So this is how you need to, you don't, there's no stop for your journey. It just goes on and on. We need to work on awareness. There's a glamour attached to this cleft lip and palate because so-called beautiful lady, Aishwarya Rai, is a brand ambassador for this. And it's an Oscar smile. They just show only this portion. But now she is. So those who are interested, please log on to the Smile Pinky. This is a special Oscar Award winning movie. They highlighted that, in Indian context, we have these kind of kids. Then now the situation is not so this. There are a lot of improvement that is being done. So this is something, you just see the brightness of her eyes compared to this and this. So for this brightness, we speech language pathologists also can contribute. Okay. Why is this? This is something which is close to my heart. I say that it's my extended family. All the work that I did from this is not my work. I believe in surrendering I and upholding we. These are the people who just said yes for all my crazy ideas of, can we do this? Can we do that? This. Yes, they did it. And cleft palate was sometime, it was not focused anywhere. Now, a lot of studies have been done. It's been taken in terms of PhD projects, dissertation. So I owe to all this, whatever I did, to these young minds who really sat with me to understand and then helped significantly to have this documentation. I take this platform to say thank you to all of them. I don't know how many of them are listening though. Dr. Kalam says that, we need to dream. There are some dreams, which you can dream when you sleep. There are some dreams which will not allow you to dream. I think the young minds, when they have this dream, which will keep on disturbing them, what did I contribute to this field? I have been given a salary of so-and-so. I have been given a responsibility of so-and-so. Did I really deserve this? Did I really made an impact? Did I really brought a change in the quality of life in these individuals? I think we need to answer to ourselves. In 2011, this unit was started at All India Institute of Speech and Hearing, a specialized clinic. Never thought that, there's some publication emerges with this, there's some data accumulation, all that. Yes, it's a humble beginning, it's humble contribution in this field, thanks to Professor Rupa Madam, who really inspired because she took the initiative of creating awareness. And my two directors, Dr. Jairam sir, who sat and told that, no, don't cry for unit, you write the proposal, you will get it. Yes, sir, I know this is today's, I have to say that something. And my mentor, Savitri Madam, who said this for 10 to 12 years that I was looking for this, I got it. And I could do a little bit of work. And then I thank Dr. Nataraj sir, whom I met on the first day of my speech and hearing life. And today I'm here to present in front of you a small work that is being done, just to tell the students that how much your work can bring a smile on somebody's face, not only on child, in the parents too. So once again, Dr. Ratna sir, you taught us the ethics of speech therapy in first PSC. I think my batch was the last batch to listen from you, and I'm happy that I'm seeing you. And I am happy that Geeta Madam, my teacher, is also there. So in front of all of you, a small presentation. Hopefully I am able to create interest among the young minds. So once again, Nataraj sir, thank you very much for giving this opportunity.
Thank you very much, ma'am. It was a very, very informative session. Throughout the presentation, you have highlighted the concept of Make in India, wherein it was demonstrated that how using a very simple low-tech devices, it was still possible to continue the therapy services. The success stories which were presented regarding the early intervention were very overwhelming, and the numerous scientific presentations provided were just adding on more and more color to the presentation, ma'am. Thank you very much.
Okay, should I answer to these questions, Sanjana?
Yes, ma'am, if possible, can we take it up?
Yeah, sure. One thing I say that any time, even at midnight, 1 o'clock, if they wake me up and they say that what do you want to teach, I say anything to do with the cleft lip and palate. So that's the way. And I was thinking 1 week with that. I was initially worried, saying that oh, they've given me at 4 o'clock. Whether the students will be feeling. And I said it's okay. In Kannada, we have a saying that G. S. Rudrappa, a noted poet, says ಎಲ್ಲರೂ ಕೇಳಲೆಂದು ನಾನು ಹಾಡುವುದಿಲ್ಲ ಹಾಡುವುದು ಅನಿವಾರ್ಯ. I am not here to say that all of you listen to me. It's my passion. So I'm here to share my passion. So if this is going to inspire one or two to think that let me just move on to this field which is not explored much, let me just bring a change in those 28,000 children who are going to be born every year, I think that gives me a smile. So the first question is how cleft lip and palate problems differs at various stages like adult child. I think I answered. I said in the beginning, it is more of development issue, delay, a deviant. And then when it goes to an adult, it is more of few of the errors are going to disappear, but the intelligibility issue remains the same. And the inferiority complex will make them to speak slow with a closed mouth approach so that they're not audible. So when they speak, most often you can see, you ask them to count, they say, the same thing, if they say 1, 2, 3, 4, you can see that the variation. So this is how that you need to work. In adults, the errors are much less compared to this. I think I answered this when I was discussing. The second question is, individuals with cleft lip and palate since birth, surgery was done with 3 years, but don't provide speech therapy. No. We provide speech therapy. See, whatever I highlighted, I had a 1-year child sitting there. So please, you give therapy soon after the palate is repaired. Even if it is not repaired, there's no harm. A parallel speech stimulation can be given. And she says, individual didn't develop speech. Can we provide speech therapy now? You can provide the speech therapy at 16 years. Here, the goals will be different. See, at 3 years or 5th year or 6th year, I will be working more on making the child to have an intelligible speech. But at the age of 16 years or 26 years, 30 years, when they come, now it is habituated so much, the wrong pattern, the wrong compensatory articulation. Now I will be making them to work towards an acceptable speech. The acceptable speech is different. The acceptable speech is, my name is Pushpa. So this is acceptable speech. But normal speech is, my name is Pushpa. So at 16 years, if they want to attend for 1 or 2 months, I can only think of an acceptable speech because it's too late. But if they are willing, if they want to continue, see, this is a month of creating awareness for the cleft lip and palate. I have my live phone-in program day after tomorrow, and I'm going to share one of the video, Karthik, through our social media next week, where when he came to us at the young age, how I started working and now how he is. Exactly, if the person is very much motivated, we can achieve a good speech. Individual has normal hearing and normal IQ. See, if they have normal hearing, normal IQ, if they have a cleft lip and palate, then we say that as a non-syndromic. So they're non-syndromic. So non-syndromic will not have much problem, but the syndromic will have more problem. How useful are non-speech activities? Okay, so Spurti, initially they were just saying that, the blowing exercises, all those exercises which are cited by Morris in her book, came up as a kind of therapy measures. But please remember, they are not the therapy measures for improving the oral pressure, velopharyngeal closure. But you have to remember that these activities help the child to build the oral pressure, which is very, very much required for speech production. If I have to say, see, stop, fricative, affricate. Ha, tha, kha, cha, tha. It requires a string. So this is the kind of work that we need to do to make the child understand the different kind of closures. Okay, I think I answered Spurti. So that's how I used those techniques in the beginning. The children started liking, especially early intervention. Okay, so now Sushmita went to move from one sound to another. Today's presentation, I highlight more on early intervention for language. Speech, I'm waiting, my PhD student Sushma to complete, and I'll be sharing it. See, we are going to take the cutoff criteria 60%. Van Rijper, when he proposed the training on perception, highlighted that we need to have 70% to move from one sound to another. But McCabe and Bradley, when they proposed multiple phoneme approach, they came up with the technique that you don't have to go for establishment transfer generalization, because you have a child who's sitting in front of you having many sound errors, multiple phoneme. So that's how he said, take one sound, work at the level of establishment, leave the rest to the mothers, take another sound. So in that way, depending on how many days they are going to come, you can plan. So very difficult to say that this is the only thing. You can just have 50% and please allow the mothers or parents to work with the child. Train them, that is what is required. So Sushmita, I think I answered 50 to 60% criteria. Ramya Bhatt, is the language problems in CLP is because of CLP in all cases? No. Cleft lip and palate is a congenital condition, okay? But the child has got the innate capacity to speak. What is required, at the first, immediately after the birth, what we require is, the infant is going to be cuddled, pampered. But here what happens is, why did I get this child? Maybe somebody cursed it or that, the bond, the maternal bond, the bond with the parents which are going to be established is disrupted here. So the cleft lip and palate is not the reason, but the consequence of the cleft lip and palate, the acceptance from the parents and the family members. So because of this, over the years, the child, started saying that something. He's trying to say, he wants milk. Okay, take it. So they doesn't want the child to speak because they can't understand. Some people feel that, if the child is, trying to say something, that they are giving a lot of problems. So all these are the kind of myths. So we need to work against the myth and we have to go ahead. So all combination of factors, Ramya, we have to sit, analyze, spend time with parents. Parents are the root cause for many things. So if you treat the mother, half of our problems are solved. Which is the best stimuli for assessing the nasality? There are a lot of debate on that. We can go from the phoneme level to word level and sentences loaded with oral and pressure consonants. The oral consonants. See, Bobby bought a ball, Mama made a lemon jab. These are the kind of things that has been cited by Ankumar. So you can start using this or in your own language, whatever you know. Baba, Tata, Tata, oral sounds. So you can just ask them to say, and sentences you can make in such a way that, the MLU should be only 3 words, not too much. Are there any mobile apps to work with cleft lip and palate case? There are no mobile apps as such. We have to tell them not to work with, not to be with the mobile. This is a request, please, encourage the interaction. The speech development takes place in such a way that, the mother has to interact. The interaction should be active, encourage, accept, modify. What happens when you give a mobile? So I strongly believe that, we have to say no to mobile. Maybe mobile apps might help you to give the stimuli. Okay, so those kind of things are not there. The articulation drill material we have developed, which may be kind of, it might be released maybe after August 9th, our annual day. I'm just having the hope. So those drill material may be helpful. The changes in therapy, it's exactly, the syndromes. Once if it is a syndromic case, naturally, depending on the associated problem, if the child has got a Peary-Robbins syndrome, we need to work with the plastic surgeons, maxillofacial surgeon. because the jaw, they can't move, they can't open widely. We might have to use the bite blocks. Down syndrome, we need to work with again other professionals. So depending on what they exhibit the problem, the therapy keeps changing, but it is challenging. So I think I answered all the questions.
All the questions have been answered, ma'am. The questions posted in the Q&A section were a proof regarding the impact of your presentation that you had on the audience, and even the chat box is filled with applauding messages from Professor Rangasai as well as Indira ma'am.
Oh, I'm happy, when I see Indira madam's comment and Rangasai says, sir, madam, it means a lot to me. Indira madam, I think she saw us in therapy, the basic things about therapy. Theory was taught by Ratna sir and practicals was by Indira madam. So ma'am, I hope that, I made you to smile saying that, whatever you taught that, I started implementing. The journey of learning there's no end for it. The more we try to learn, the more we try to collaborate, the more we surrender ego and to accept things and to work on a mission to bring change in someone's life. I don't think we will be called as professionals. So dear students, my takeaway message to all of you is please, wherever, whoever, this field is a field, which is challenging, and the commitment has to come from you. Never ever say that, I tried for so many days, nothing is happening. Nothing will happen in the beginning. The journey, as I said, from unintelligible to intelligibility is not so easy. So you have to wait, then work hard. Surely you will make one day, parents smile for your therapy.
Thank you, Dr. Pushpa, for sharing your extensive, intensive, and interesting experience with the cleft palate. And that is one of the reasons why I thought of inviting you for the webinar. Thank you for accepting our invitation and taking part in this webinar and sharing your valuable information and experience. Thank you.
Thank you, sir.
Over to Mrs. Sanjana.
Yes, sir. I request Pushpavati to kindly accept the letter of appreciation for being the resource person for today's webinar, ma'am.
Thank you, sir.
Thank you, ma'am. You also mentioned that, ma'am, in spite of your busy schedule, you have been attending at least 2 sessions per day for the webinar. We are very grateful and thankful to you, ma'am.
Yes. As I said, I'll be doing my work, but my system will be on because today, after a long time, I think I saw Radhika, who was my senior, thanks to Nataraj sir, and learned about the work that is being done. Of course, Dr. Nandu, and I think yesterday I missed it. So I make it a point to attend. Thank you, sir. Thank you for this opportunity.
Thank you, ma'am. Participants, kindly note that the feedback link is being posted in the chat box. I request you all to fill the form and kindly provide your feedback regarding today's sessions. Tomorrow we have 4 sessions scheduled. So 2 sessions are in the morning and 2 are in the evening. We have 2 sessions between 10 and 11 and 11 to 12. And 2 more in the evening between 4 and 6. So I request you all to kindly make it convenient to join us at the scheduled date and time tomorrow.
Okay, thank you.
Thank you all.
Thank you, sir.
You can use the same link what is being given for all the other days to join the webinar tomorrow.
Okay, thank you.
Thank you. Shall we close the meeting, sir, with your permission?
Yeah, go ahead, please.
Yeah. Thank you, sir. Thank you very much.